Guten Morgen zusammen. My name's Leanne Hartnett and I'm an emergency physician at Fiona Stanley Hospital in Western Australia, clearly fluent in German. And I'd like to share with you what I learnt from Mr. Wally Jalok. So Mr. Jalok was a 65-year-old man who was brought into emergency by ambulance late one evening last year with acute shortness of breath and tightness across his chest. He had a significant history of motor neuron disease, such that he was now wheelchair-bound and quite reliant on his wife for assistance with activities of daily living. He slept propped upright because he got short of breath lying flat. But despite this, he could tell us that he still had a good quality of life. He got enjoyment from getting out and about with his wife, spending time with family, and reading the newspaper. But he was aware that he had a progressive disease. He knew what the future held, and he decided that in the event he should become very unwell, he wouldn't want any invasive interventions or CPR, but he was otherwise open to any treatments that would give him more time or quality of life. So here he was this evening. He was a bit pale, tachypneic. He was alert and mentally sharp though. He was afebrile, tachycardic, and his blood pressure was 98 on 52, and he could tell us that his usual blood pressure was about 120 on 70. His chest was clear, his heart sounds were dual with no murmurs, and there were no signs of a DVT. His ECG just showed a sinus tachycardia without any specific evidence of an AMI or PE. So I was still quite suspicious of a PE at this point, and I would have loved to get a CTPA, but Mr. Jalok was pretty sure he wasn't going to be able to lie flat for that CTPA. So we wheeled the ultrasound machine into the bedside. Now this was a lovely challenge for me with this patient sitting bolt upright, puffing away, but this is my attempt at a parasternal long axis view, and I think you can still say that the RV doesn't seem to be doing too much, and the LV systolic function seems okay. This more telling parasternal short axis view shows a big RV compared to the smaller LV, and an intraventricular septum that's almost completely flattening in diastole, where the LV should retain its round shape throughout the cardiac cycle. And this attempt at an apical 4-chamber view isn't showing the left heart too well, but you can see that the RV is big and hypodynamic. And I got the impression that there was something flicking about in his right atrium. So I went back to a parasternal location and angled the probe towards his right heart, and sure enough, there was this mobile, cord-like thrombus flicking about in his right atrium. So at this point, I am feeling freaking awesome. From a quick history examination and basic bedside echo, I'd worked out that this man had acute PE with right heart strain, so submassive via our usual criteria because his systolic was never less than 90 and never more than 40 from his usual systolic blood pressure, and he had residual thrombus in his right atrium. So in my hospital, we tend to just anticoagulate and observe submassive PEs. But surely this guy's at an increased risk, right, because of this clot in his right atrium. And that's when panic set in, as I realised, well, I wondered if there was something more I should be doing, and realised that I didn't know. So I phoned a friend, and fortunately Dr. Adrian Gowdy was on shift with me that day. He generally knows most things. But we had a chat and a quick review of the literature before speaking to the patient about his options. And this is what we found. This pooled analysis was published in the Journal of Vascular Medicine in 2015, and they aimed to compare the efficacy of the different treatment options for acute pulmonary embolism with right heart thrombus. They did this by a search of the literature from 1992 to 2013 using search terms cardiac thrombus, atrial thrombus, and ventricular thrombus. And they included studies if they reported on patients that had acute PE, plus right atrial or right ventricular thrombus, plus the paper reported on the therapy given and the patient outcome. They had some fairly reasonable exclusion criteria, and it was mainly if the choice of therapy for that patient was limited because of a contraindication to one or more of the usual treatments. And their aim was to compare the efficacy of those different treatments with the primary endpoint being in-hospital survival or death. They found 166 papers for inclusion, and they were mostly single case reports. There were a few retrospective small case series, no prospective data out there on it. And they found then 328 patients from these 166 papers for analysis. This was the patient sort of demographic and clinical info, as well as the echo data and the treatment outcomes and the treatments given and the patient outcomes. And I just wanted to point out that the patients seemed sicker in the group that got thrombolysis. 63% of those that received thrombolysis were hemodynamically unstable, compared to 38% who received anticoagulation only, and 28% in the group that got an embolectomy. So breaking it down, 11 patients received no treatment, 70 received anticoagulation only, 122 received systemic thrombolysis, 120 had a surgical embolectomy, and 5 had some sort of catheter-directed therapy. Actually, that's not entirely true. 115 were meant to get anticoagulation only, but they were switched to either thrombolysis or embolectomy arms because of clinical deterioration. But the analysis was done based on the final most aggressive treatment they received, so here's those results. Overall, in-hospital mortality was 23.2%. In those that received no treatment, it was 91.7%. In those that received anticoagulation only, 37.1%. In those that received thrombolysis, 13.9%. Embolectomy patients, 18.3%. And they didn't specifically report on the outcomes of the catheter-based group because there was such few numbers. Now, if you break those numbers down based on whether patients were hemodynamically stable or unstable, you can see that even hemodynamically stable patients who received anticoagulation only had a 28.2% mortality, compared to 7.6% in those that received thrombolysis and 13.1% in those that had an embolectomy. And you can basically double those numbers across the board if the patient was hemodynamically unstable. So, whether hemodynamically stable or unstable, it seems a probability of survival is better with thrombolysis or embolectomy, with an odds ratio for survival with thrombolysis of 4.8 and with embolectomy of 2.6 compared to anticoagulation alone. The rate of any complication was similar in both groups, and I just wanted to point out that of the 122 that received systemic thrombolysis, there was one major bleed that had the kitchen sink thrown at them, one intracranial bleed, and 3 minor bleeds. In conclusion, patients with acute pulmonary embolism and right heart thrombi should be regarded as high risk in your minds and in your hospital PE guidelines because they have such high mortality. Thrombolysis and embolectomy are both effective strategies. Thrombolysis is possibly better, and who knows, maybe these catheter-directed therapies are better still, but there's just no good data on that at the moment. And it seems that the risk of major bleeding post-thrombolysis in this group of patients is acceptably low. Yes, there are limitations of this study. It's all retrospective descriptive data, but we're unlikely to have any RCTs around the corner because it's such an uncommon condition. Reporting bias, likely, but I know that if I had a patient come into ED sick and I gave them an intervention and they did well, I'd be much more likely to write it up than if I gave them the intervention and they did badly. So perhaps this paper underestimates the mortality associated with this condition. And yes, there was some missing data and the groups weren't well matched, but if anything, the patients were sicker in the thrombolysis group, so I still think it's a useful guide for us. So what happened to Mr. Gillock? Well, he did really well. We thrombolysed him and his heart rate come down from 130 to 90 within 4 hours post-thrombolysis. He was admitted to the ward under the respiratory guise and was discharged home 36 hours later on rivaroxaban. That is pretty much it, and I apologise at this point that this sonobite wasn't very sono-y, but I hope this case has shown how occasionally some basic echo skills can make a massive difference for your patient, and also hopefully passed on something that I previously didn't know about thrombus in transit. With more time, I would have loved to show you some more images of patients I've seen with acute pulmonary embolism and right heart strain, or maybe chatted about some tips for getting windows in the cardiac arrest situation, which is always tricky when there's so much going on in the chest. But feel free to come and have a chat to me in the Sim House at lunchtime or at any time. Thank you.